Welcome to SMA's Southern Medicine podcast. Practicing medicine in the southeastern United States presents unique challenges for healthcare professionals. The South's heavily rural population and limited resources require medical professionals to be more resourceful in their approach to providing quality care. SMA's Southern Medicine podcast addresses these issues by drawing on the experience of healthcare leaders who provide a multi-specialty, interdisciplinary team approach to medicine for the purpose of providing better care for the Southern patient population.
Hello, everyone. I'm Andy Mohan, and I'm the co-chairman of the Digital Health and Innovation Committee. I'm here along with Mr. Dylan Stevenson, who is our digital media specialist at the Southern Medical Association. Additionally, we have a guest moderator, Mr. Fred Newmark, who has joined us for the last couple of podcasts. Fred is the co-founder and managing partner of Newmark Healthcare Services. He also has a video series called Behind the Curtain of Healthcare that can be found on YouTube, which is his video podcast talking about various topics in healthcare. Thanks again for joining us, Fred. Our guest today is Dr. Meena Makhijani, who is a geriatrician in the Los Angeles area. She works for UCLA in an outpatient clinic and doing nursing home work. She is also the chief of staff of the Motion Picture and Television Fund Hospital. Dr. Makhijani is triple board certified in geriatric medicine, family medicine, and integrative medicine. She had a prior career as an engineer and has a passion for global relief work. Dr. Makhijani will discuss with us the COVID-19 response in her practice, how they have been able to manage the situation in nursing homes, how technology has changed her practice, and what the new norm looks like for her and her patients. Before we begin, I would like to encourage our listeners to visit sma.org/podcast to subscribe to the Southern Medicine Podcast, as well as other SMA podcasts. Meena and Fred, thank you for joining us today. So before we start discussing your experience with the crisis, Meena, I'd like to know how you and your family are doing under the current circumstances.
Thank you, Andy, Dr. Mohan. Thank you so much for having me, and Fred. Well, my family, everybody's doing fine. Everybody's healthy, thank goodness. And, you know, my mom's attitude today is her birthday. It's a milestone birthday for her. And I was talking to her about, you know, how disappointed I am that we can't celebrate given the strict stay-at-home orders that we still have today, you know, April 24th, 2020. And so I was talking to her about that, and she said, you know what, this is a short-term situation. We're thinking long-term. We want our family to be around for a very long time. And so these few days, weeks, months, whatever they are, it doesn't really matter because we're thinking big picture. We want to all be healthy. And so, you know, I think that was just such a great attitude for me to hear because people are just getting so fed up of everything. And so, you know, my parents are really strictly adhering to the stay at home. They have literally not left their house since March 10th or so. So they are being, you know, very good about that and keeping active in the home. And, you know, we keep in touch by phone. I stop by and drop off groceries from a distance, say hello from like a very far distance while they're inside and I'm outside. And so we're able to keep in touch that way. But, you know, certainly a very different reality, of course, for everybody.
You mentioned the word groceries. Our groceries are still in the garage from 2 days ago. We have cleaned them all down with alcohol, but we have still not brought them into the home. We are ultra conservative, high at risk in our 60s, taking every precaution. So yes, times are certainly different. You know, what's the situation where you work day in and day out? Because you have a specialized focus, which makes you a great guest, working with those of us that are biologically towards the call it the back nine, if you will. So what's the situation with your patient base, what you see day in and day out, and the conditions that you're enduring right now professionally?
Sure. So I am a geriatrician, as was probably mentioned. And so I work on a campus in the Los Angeles area that houses about 300 older adults. So these are people who are ages 70 and up. So it's a very at-risk population. So we have been really concerned about our patient population ever since the end of February, let's say, really following the news. This is before things had really hit the U.S., but we were just, keenly aware of the situation and how it could go if it were to reach us, which unfortunately it did. But what we started doing to prepare is we locked down our campus in the beginning of March. So no visitors were allowed to come anymore, it's very difficult when you have, so many older adults and their families can't come in, friends, volunteers, all that sort of thing. But we were just very, very concerned about how things could go and knew that this is what we had to do. And we have people in all ranges of health and abilities on this campus. So some are completely independent, they drive, they go places, they live in their own little cottage, take their own medications. Some are in the assisted living area, so they need help with some of the activities of daily living, bathing, dressing, etc., their medications. Then we have a nursing home unit, and then we have a locked dementia unit. So we have really the full spectrum there. So it's been just a tough time for everybody in terms of isolation. But what unfortunately happened about 3 weeks ago or so is we did get a positive case in our nursing home side. And that has expanded to several cases and several deaths. And so it's been just such a very difficult time. Everybody there is very close and like a family, so it's really like losing family members in a way. So it's just been so difficult to really see that and go through that. It's been difficult for the patients. Their families are not allowed to visit. So that's been just such a tragedy on top of everything. It's been difficult for the staff. Many people are very scared and don't want to be working in this area. We've built a separate COVID ward, not built, but kind of resurrected an old part of our hospital setting there and made it a COVID ward. So that's where everybody's been housed, and we're doing our best with PPE and infection control. But it's certainly a very crazy time and crazy situation there.
What measures, once you went into lockdown mode, being that family and friends are no longer allowed to travel onto the premises and see their friends and family members, what precautions is this institution taking with the workers, physicians, dietitians, all the people that support a community like this? What sort of screening or new aspects of protecting that group of patients is taken place since the lockdown?
Right, that's a great question, very important. So at the same time that we locked down the campus here, which again was well before there was a statewide lockdown, but at that time we also started screening of every employee that came through the campus. So everyone was receiving temperature screens as well as questionnaires about exposures, cough, different symptoms, and those symptoms keep evolving all the time until this day of what we're screening with. But basically that's how we've been checking. We've been asking people to report also if they had any symptoms to stay home, and if they work in any other facilities, because a lot of people in the nursing home arena work in multiple facilities in the area, which are all at high risk. And so we've been asking people to kind of declare that if they are working in different places, especially if those facilities have had any positive cases.
So out of those, out of how many people or how many patients do you have in your nursing home right now?
Well, in the overall nursing home, it's about 80 patients.
Okay. So 80 patients, and out of that, you had 7 of them that had perished.
We have had 5 as of now.
5, okay, but you said 7, so 7 were positive. So how many are positive now?
Sorry, I don't know what I said about 7, but we've had maybe well over 20 that were positive, probably even more than that, right? So several we have so many that are still positive, and we keep retesting and following the new guidelines of testing, which also is changing all the time. So we're kind of testing them periodically. If they, for example, haven't had symptoms for 72 hours, that's one marker that they're asymptomatic now, you can retest. And we're testing, and many are still coming back positive. So we have to continue with these same isolation precautions, treating them definitely as a positive patient based on the testing.
And it's all, so your COVID patients or COVID positive patients are all in a separate area. That
Right.
area is not, I mean, there's no negative pressure or something to kind of keep it in that environment secure from the other environment, correct?
Exactly. So that's a really important point. That's a way we really kind of differ from hospitals, for example. So we don't have any negative pressure rooms. Our setup it's kind of like a hospital in that they're separate rooms, but the doors are open, everything is kind of flowing. We have a ventilation system. Our administration has bought air purifiers for each room. So we're doing our best there, but it's certainly not that it's a completely controlled environment.
Meena, let me ask, when you first went on lockdown all the way through today, and this is really more about the question is really leaning more into the mental, psychological, emotional situation. Um, how did everybody generally respond? Because you locked down early. I mean, March 1st, we were, I think, still just as a country, from a mass consumption perspective, still barely wrapping our heads around this.
Right.
So you chose, and your facility and leadership chose to take very early first step action. How did the folks that are there respond? Did they seem to understand what was going on? Were they getting enough information that they understood the rationale behind it? And how have they um, dealt with things as things have actually, unfortunately, continued to be a challenge?
Right. So it's certainly been a challenge from the beginning, but I would say that our facility dealt with it, meaning our residents who live there dealt with it extremely well, because given the nature of our campus, where it's all older adults who live there, we have had several mini lockdowns and quarantines through the years.
Mm,
Basically, almost every year, they end up being on a quarantine in one building or the other that we have on the campus because of usually of flu outbreaks. Sometimes it's a norovirus outbreak. So our infection control is very robust there, and they get locked down the minute there's a positive case in one of the areas. And so
okay.
in that sense, it's something they're used to. But this is, of course,
Mhm.
so different and extreme, you could say, compared to anything that anyone's been through before. One of my patients yesterday who I saw in my clinic, so who is not a COVID patient, not from the nursing home side where we have positive cases, she's in her 90s, and she said, I've never experienced anything like this in my life. And I said, what about wars and things? She's like,
Yeah,
nothing has been like this,
yeah.
where we are this isolated, where we're this scared. So that was really enlightening to hear how people are still responding now. So even though it's been more than a month, probably it's weighing on people more now, I would say, the separation from their families and even from their friends on the campus, since
Yeah.
peer engagement is so important. Even that is completely limited. There's no more bingo, there's no more group dining, any of those activities. So that's definitely been hard for the residents, but I'd say, at least from everybody I've spoken to, they do understand. At first, when this happened, people were not adhering as much. Many were still going across the street to the shopping center and, to
Hmm.
the coffee shop and doing all that and coming back. And nobody was wearing masks at that point. That came several weeks later. So our campus handed out masks to everybody, and people were still not following that. So it's been a progression of what is actually being adhered to and the understanding. But we're also just trying to offer a lot of information to everybody. We have entertainment via television for everybody on the
Hmm.
campus. So trying to just keep engaged with what's
Yes.
happening and keep them engaged and involved with each other as well,
So from a
virtually.
behavioral health standpoint,
Hmm.
um, and it hasn't been that long. I mean, in essence, it's been a few months. Feels like a few years, but it's been a few
Right,
months.
right.
Um, has there been any noticeable change in that capacity for you or any of the behavioral health specialists that are on staff?
Right, that's a great question also. So in the nursing home side, from what I have been told, because I haven't been going into that area, we're trying to
Mm-hmm.
limit our exposure since I'm working on the COVID unit. But what I've heard is because, let's say in our dementia part of the nursing home, people usually just are able to kind of wander in that setting because it's a locked setting. And so
Mm-hmm.
they're kind of encouraged to be free and go to these different areas. There are different kind of activity areas there, like a washing machine area and like a little grocery store area, different things like that. We're trying to restrict that to some degree, but we don't want to completely stop that because with patients with dementia, it can just be so disorienting and so
Mm-hmm.
traumatic in that way. And we
Mm-hmm.
feel, based on past experience and data, that that can even be worse for their health. So we have to really balance it because, of course, we don't want them to pick up COVID, but at the same
Right.
time, we
Right.
can't completely shut them down mentally because that has
So,
such a physical impact as well.
so this is a novice question, but is the reason that it appears COVID appears more readily on the nursing home side, is it strictly just the difference in social distancing in a nursing home setting than the other settings within this facility and living situation?
Yes, definitely that's a huge factor, absolutely. So in the nursing home, for the most part, it's all shared rooms.
Okay.
So,
Yeah.
definitely there's just more contact that way.
Yeah.
And also because nursing home patients end up needing more care, and so you just have a lot more people in and out of the rooms and in close contact with the individuals themselves. So, and again, as I mentioned, a lot of the employees work in different facilities. So there's so much potential exposure. So even when we got our first case, or even before we got our first case, we knew that if we do get a positive COVID case, it's going to be brought in from the outside. It's definitely from an employee. That's just
Mm-hmm.
how it's going to be because nobody else is there. It's not going to just pop up inherently in a patient. So there's, again, just so much of that contact constantly. And whereas in our, let's say, assisted living, even though those are also older adults, but they don't have the same level of interaction with other staff or other individuals. They have their own rooms, their own bathrooms. So definitely that does make a difference on top of the fact that older adults in general are just so much more at risk.
Well, to that point, the individual that the patient that contracted the virus initially, your first patient, did you guys do any contact tracing to figure out where it came from?
Definitely. So it was hard to really trace it down from the employee. So we still have not been able to identify the exact individual, although several of the employees have tested positive in the meantime. But we definitely started there, immediately isolated that patient, found out everybody as far as we could who's worked with that patient, looked at that individual's roommate in their little kind of cohort area in the nursing home of where they would eat their meals just with a few other people, and immediately start testing that whole individual section of the nursing home. So we started that way and then kind of spread as symptoms spread, so just kind of expanding it accordingly.
So, Meena, let me ask, and I'm honestly coming from, I'll use the word mass consumption because I'm not a clinician. So I'm receiving information not on the front line like you do. I'm receiving it through the telly, as we would say if I was from England. So when this all like suddenly became more prevalent to our awareness as, human beings here in this country, it's kind of, if my memory serves me right, started with Washington State's nursing home outbreak. That was like for me the original hotspot that just my memory recalls.
Right.
And it's seemingly the attention, it kind of then waned from our high risk elderly to the surge into hospitals. And then from that point on, for me as a consumer of information, every day it really, the hardcore focus was on everything going on at the hospital level, and appropriately so, especially in these congested cities that unfortunately have been so hard hit. And it almost feels to me like the nursing home side got lost in the shuffle. I don't know if you feel this way. I'm just giving you my perception, and then there will be a question within the next 3 hours, I promise. Do you feel like in some way the nursing home, from an informational perspective, started to take a back seat? And I guess the second part is, was there lag in nursing home protocols from the healthcare experts versus everything that was so heavily focused on the hospital side?
I think that's such an excellent and very astute observation that you made there, and I'm so glad you brought that up, especially since I'm so passionate about the care for the elderly and older adults. But I absolutely agree with you. So, of course, there was that huge focus in Washington State when really that was the epicenter of all this in the U.S. was that particular nursing home. And you're right. After that, we really haven't heard much about nursing homes, but they have still been hit tremendously across the country. So even in Los Angeles, there are several nursing homes that have had huge outbreaks. There was one about 2 weeks ago that was in the news, at least locally, where no staff showed up to work one particular day. And from what I understand, that was just because, one, they were so scared to be working there and felt unprotected. So we keep hearing about the PPE issues. And like you said, that's mainly focused around hospitals when we're hearing about that. But I think nursing homes and assisted living facilities, probably throughout the country, definitely in Los Angeles, are even more poorly equipped than hospitals are, because it's not something that we deal with on that same scale. So although we usually have some kind of infection control, because people can have particular infections like MRSA and things like that, so we definitely in nursing homes are always equipped for that. But again, it's a very small scale. It might just be a few patients at a time. But masking, et cetera, that's not something that's typically stocked or done in nursing homes. So definitely we are at a disadvantage that way in having the supplies even from the get-go, from having the kind of setup in the facility to isolate patients, because again, the majority of nursing homes are 2 or 3 patients in a room. Many have 3 patients in a room. So just, think about the impact there. So you're absolutely right that there's just such a huge risk and huge outbreaks going on now that I just think we don't hear about for multiple reasons. I think that there is unfortunately still just a bias against older adults, definitely in this country. And so that's not of as much interest, might be part of it. I mean, although we have been hearing a lot in the news that older adults are at risk, stay away from them, that sort of thing. But in terms of the shining a light on this huge issue, and again, that these older adults in the facilities, they can't have any visitors, whether it's a COVID unit or not. Most of them have just closed off to visitors completely. And that's just so heartbreaking for the residents there, for their families there who don't know what's going on exactly. So absolutely, this is an ongoing major issue across the country.
So Meena, let me ask, do you feel that from a protocol perspective, and again, I'm not a physician, so I haven't been paying attention to the things that you, or if you were a physician at a hospital, I clearly don't have the granular hardwiring that you would have. But have the protocols moved as quickly for the nursing home side? I'm talking of like national footprint protocols, as we hear going on overall for either hospitals or how to handle it. Do you feel that did it move fast enough so that it was standardized, if you will, that like all nursing home staff and personnel and physicians were being guided in a timely manner? Or do you feel like there was some lag so that you're learning from each other collaboratively, and if there's a better way to do it, is there any kind of conduit of communication that's helping everybody out there that's on the nursing home side?
Yes, so there is basically most facilities, from what I see, are following the guidelines put out by the CDC and also by their individual counties. So each county has their Department of Public Health, and they're issuing guidelines that are being updated all the time. And over here in LA, the LA County Department of Public Health has calls every day. And so the infection control people from each facility are getting on the calls. sharing what their needs are. So that's been a really great resource because one, we're learning from each other, but two, if a particular facility has a need, because many are just individual facilities, some might be part of a group that might own 3 different nursing homes, for example, but usually they're kind of more on an individual or very small scale. So you're kind of fending for yourself in that way in terms of what the guidelines should be, what resources you can acquire. So this has been great that there are these resources to at least share what your needs are or share what your questions are. So we kind of go back and forth. So I'm involved a lot with my particular facilities. We have daily calls with our entire administration, and I'm chief of staff, so I get to be involved in a lot of those, and also with our medical team. So just whenever we have questions about anything, because this is so unprecedented, and there is no one guidebook or set of guidelines that is for everybody, that everybody could follow. So we're always just kind of collaborating with each other at the facility, with the LA County, with the state, with the nursing home coalitions that exist on a national level. So that's been great to be able to really share with each other across the country, because there's just constantly information coming out. But you're right that it is a little different from hospitals in that way. I don't know if there's been so much of a lag, because on one hand, because nursing homes are smaller, it's in that sense easier to implement things. A lot of hospitals are just so massive or part of large hospital conglomerations, and so there are just so many layers of administration and bureaucracy between them and even the doctors or the providers, any of the healthcare team. And I think that's what's led to a lot of the problems that we're hearing about in the news, and people are really dissatisfied because they're not hearing from the higher levels, and they're not able to voice their concerns. So on the nursing home scale, it's different that way, but also you have so many different doctors coming in and out. We're not employed usually directly by the nursing home.
Right.
So there are a lot of differences, definitely, but at least I do feel that from what I've seen, that the healthcare team is able to give a lot of input on the nursing home level.
So kind of going back to the personal protective equipment, what are you guys asking your staff to do, and how are they responding? So are they, because you obviously have a lack of an adequate quantity of PPE. So how are they being told to reuse this PPE, and how are they responding to that?
Right. Yeah, that's definitely been a huge issue. And what I can say about my facility is the lack of PPE. I don't want to say lack, but it is a little limited in terms of what ideally we would like to have. And that is not at all due to our administration. I will definitely say that. It's due to the national supply. And it's just been really interesting for me to be part of these meetings where we're hearing from our supply director, and he's saying you just can't get anything anywhere, and then there's all this price gouging, and then you'll put in an order that'll be accepted, and then it gets canceled a couple days prior to the shipment.
Oh, wow.
So it's all these really crazy things that are happening. And so I think that was really interesting for me, because from the news it just sounds like hospitals are not providing PPE for whatever reason. In many cases, that's kind of the sense I've got. But at least here I see that it's really a supply issue, which is really unfortunate that that's even happening, especially in the US where there is so much abundance. But it's not for a lack of being willing to pay for it or anything like that, but it's just you cannot actually procure some of these. So what we're doing is we definitely are looking at projections of, okay, how much do we need? How many staff do we have? How many shifts? How many rooms? How many different roles do people have that are in and out of each room? And really trying to kind of work that out and see what our needs are. But we are limited already at this point, besides what we're projecting for the future. And so what we've had to do is definitely reuse some gowns, for example, but that each gown is only for one patient. So nobody would wear one gown to this patient and then that patient. And I'm talking about even just in our regular nursing home part, not even the COVID area. We're just trying to be extremely cautious. So that has also been a problem because at first, when we were trying to figure this out, some of the staff had to wear the same gown for that particular patient, and they were very upset about that. They felt that's unclean. They might pick up something from that individual. So we've sort of been able to modify that, go to cloth gowns that can be washed that we just have a larger supply of. So we're constantly trying to change the policies to please the staff based on their very rational concerns. So far it's working out, but yeah, it's definitely, like I mentioned, some people, no matter what, even with the adequate PPE, they're just scared to work in these settings.
So like masks, you guys, how are you sanitizing those or sterilizing? That's the proper term.
Okay, so we have enough masks. So that's one thing that we have plenty of. So we have not had to, there's no problem with masks. So we're not sanitizing or sterilizing here.
Okay.
Right, and so that's not been an issue. It's more for us, it's the gowns has been the issue because we're asking people to just gown up before every encounter.
Right. Well, I guess for you guys and a lot of other institutions or healthcare systems are having difficulties even getting masks still.
Right.
And they're still, they're having to sterilize it using all sorts of different methodologies. So I was just kind of curious about that. In terms of your practice right now, has technology or anything that has to do with technology, has that changed the way that you've practiced or made it efficient and a lot safer for you?
Yes, definitely. That has been a great tool that we've been able to use. So Medicare, right when all this started, they really kind of changed and maybe relaxed some of their rules about telehealth. And so suddenly that was something that we were able to really utilize in my clinic setting I'm talking about now, because most of my normal day is in the clinic, and then a large portion is also nursing home. But so in my clinic, suddenly we were able to make phone calls to patients, which is wonderful. We even have the capability to do video calls. However, given my patient population, where my average patient age is about 88 years old, that does not really work out too well. Most of them have not been able to figure out the video capabilities. It has to go through a smartphone and through our patient portal, and it's pretty complex. So I've maybe had 2 video visits since all this started, unfortunately, because that would just make it so much more interactive. But certainly we've really restricted our in-person visits to only things that really need to be seen in person, just for everybody's safety, especially our patients. So most of what I'm doing these days for my clinic are phone calls. So even that, a lot of my older patients don't want to do. They just don't feel it's the same, which is true. And so we're trying to convince them, but at least that way technology is really allowing us to stay connected with our patients, try to still treat them and provide care the best we can. We in our COVID unit, we did get a video capability there, so we do have that. But honestly, I haven't even tried it because I said these patients are pretty sick. I need to be there in person to actually see them and examine them. But at least it's there in case there's some change of condition when I'm not there or something like that. Definitely, technology is a great benefit in this time. I was an engineer before I went into medicine, so I'm always interested in technology and how we could leverage it in medicine. But, the bottom line is there's nothing like the in-person contact.
So you're an engineer as well. So you're a physician and engineer. Are you a lawyer too?
No, not a lawyer.
There's still time, Meena.
There's still time.
I know. I'm like, gosh, there's so much I want to do.
Meena, I'm curious. What of all the things you could have decided on as a physician, what were the compelling things for you that made you want to have your career in healthcare treat the older subset of the population? What was it what passion or what need or what kind of drove you in that direction?
Sure. So the number one thing I'd say is I love older people. I just always have. had a real connection and interest in
So
older
can I
adults.
interrupt you for 1 second? Does
Yes,
that mean
of course.
you like me more than you do Andy?
I knew you were going to say that.
I mean, well,
Maybe.
Andy and I go way back.
I know.
So
And we've never met in
he does
person,
have,
so I
right.
understand. All right. All right.
So I'd
Fair
say
enough.
it's pretty equal. How's that?
Okay. At least I'm on
Okay.
equal footing with
Thank
Andy.
you, Meena.
Go ahead, Meena. I'm sorry, dear. Go ahead.
No problem. But the other thing is, I went into medicine, or I'd always wanted to go into medicine for the goal of what so many people say is helping people. So that's really what I wanted to do. And as I thought more about it, I said, well, I really want to help an underserved population. This is why I'm going into medicine. And typically, we think of underserved populations as those in poverty. And so that's what I had thought for a while. But as I really thought more about it, I realized that the older adult population or geriatric population is incredibly underserved. And to me, one of the most underserved populations that we have in the US, in terms of resources in general, in terms of healthcare. There are very few geriatricians or specialists in geriatric medicine in the country, and it's considered a national shortage. So once I learned about those aspects, I said, well, that's what I'm going to do, because this is an area that really needs help and really deserves help. I think, elders are really our treasures, and I just feel that there's in society, they have kind of really not been held in that light for a long time, and that breaks my heart. But that's really why I said I want to do whatever I can for this particular beautiful population.
Isn't it interesting that I would agree with you, in there are other cultures where it's kind of the opposite, where the older subset, if you will, are actually revered as the wise and the cherished in many cultures. And that's not to put a blanket statement that that's how it's all is here in the U.S., but as a generalization, I think the older we get, the more obsolete, in a sense, that we feel. And in other cultures, it's not necessarily that way.
Right. No, you're absolutely right. My parents are from India, and so when I was growing up here, that was a real loss. I felt that I didn't have my grandparents here; they were in India. And so I used to really notice that when my other friends would get to spend time with their grandparents, and I would only see mine every few years, that was really something I felt acutely. And then when we would go to visit India, I definitely saw what you're describing, that where elders are really revered, and there's like center of the family unit, and there's just so much more interaction with the elders there. And so certainly that has influenced me a lot. And I think that throughout the world, things are changing a lot, though, where older adults, even in India now, there are nursing homes there, and a lot of people kind of don't have the time, let's say, to take care of their older parents or grandparents, and we're seeing a lot of shifts, similar to what we have here. And I've heard about that in so many other countries. And so it's really, interesting and sad in many ways how that's happening, but it's also just how, society is evolving. So I definitely keep looking at that. But overall, wherever we are, I hope that older adults at least have our respect, if not enough time and care from us.
So what's your sense at this point about that delicate yin and yang balance, if you will, of we're now entering that phase where there's more public conversation about relaxing the stay-at-home orders in certain areas, and I think it's up to massive debate as to what that should look like, and there's a lot of pressures on many fronts in how I think some of our leaders are making those decisions. But what is your sense about relaxing the stay-at-home situation?
Right. It makes me extremely nervous that already, as of today, I believe Georgia is relaxing a lot of their stay-at-home orders. And so It's very scary to me because on one hand, obviously we want our economy to continue functioning and thriving, and I have so many friends who are out of work at this time, so I certainly understand this need to get things moving, but I just think at this point in time, I don't think we're there yet, really. We just still have too many positive cases. It's still too early in sort of seeing the whole trajectory here of how things are going to go. And so, especially with when we're seeing what is opening. So, for example, what I read about in Georgia is it's things like nail salons and hair salons and tattoo parlors and gyms. These are all things where people are in very close contact. And so you can't really socially distance in those kind of settings. And not only between the employee and the client, like if they're doing your nails, they're right in their face practically. So not only are they very close, but then you would probably have several clients in chairs nearby. So all these kind of things, I mean, that, like I said, it just makes me really nervous about what could happen this way. So I think that, of course, you know, every state is sort of operating independently or in coalitions with states in their regions. And I know that, you know, they're looking at the science and looking at the economics and trying to make the best decisions. But I think for individuals, we still have to be really vigilant in what we're doing, no matter what the orders are. We have to really use common sense and really still limit our activities, our exposure, you know, still follow hand hygiene and wear masks, even if we are going out, because those are the kind of things that I wonder if people are allowed to go out, are they going to follow those kind of practices, which are still so important? And I think lots of times people just do look to their governments, whether it's the state or, you know, federal governments, for guidance. And I think that's part of why I'm concerned about this, that it just makes it seem like everything can pretty much go back to normal, at least in phases already. But that's really not the case.
So if you were to do a look back now from a clinician's view, would the two compelling things, or what other compelling reasons could have appeared that would have had this under greater control versus some countries that seemingly just by the numbers have done a more effective job? So for me, it's if we had responded earlier, perhaps, and if we had had more testing. Are there other mitigating things or factors outside of those two that you think could have made a difference in how we stand today versus had we taken action at another time or implemented things at another time earlier?
Right. No, I agree with you. Absolutely. It's the testing and sort of the awareness. So even when we started locking down in California, at least, we still didn't have adequate testing. And there were so many people who had very clear symptoms, I mean, as clear as we could tell about COVID symptoms, who could not access testing. Even in I work also for a very large health system, even there it was very limited in terms of who could get testing and where physically you had to go. And so, and I know I was in touch with physician friends all over the country, and that was the case everywhere, even in large hospitals. They were having patients coming in and they just had to treat them as if it was COVID without the testing capability. And so that to me is a huge issue that we've had all along. It's certainly changed now, but I absolutely agree with you that if we had had more testing capabilities earlier, it really could have changed things in terms of understanding the scope, in terms of doing smaller isolations earlier. The tracing, like Andy mentioned, that's what a lot of countries are doing. They're testing, tracing, and locking those people down. They're quarantining those areas. So it doesn't have to be a nationwide or a region-wide shutdown because you have so much more information. And I was traveling in January this year. I had gone to India and I came back in early February, and it was all over the news in India at that time. There were no cases. It was still limited to China at that point. But, you know, everybody in the world there seemed to know about it. I flew back through Dubai. People were wearing masks there. I wore a mask flying back. So I feel like there was kind of global awareness of this situation, but I just think here in the US, we were really slow to react, even though, fine, we didn't have cases, but it's a
Right.
very
Yeah.
fluid
Yeah.
world right now, and it was
Yeah.
kind of
Yeah.
inevitable that it would come. And I just think that the information was there. It's not that we didn't know about this. So
Yeah.
um, I can't point fingers or lay blame, but it's
Yeah.
just that, yes, looking back,
Yeah.
certainly we could have done things differently. Testing wise, that's something that still astounds me to this day. Even there's so many different testing labs, et cetera. It's like, why couldn't we have sort of streamlined this or shared on a global level when so many other countries, China, number one, had testing. Many other countries, Italy then had developed testing. If there was some way that we could have just kind of shared this science and gotten the
Hmm.
testing going sooner than kind of reinventing the wheel, that too, I think, would have really helped. Again, on a global scale, this just affects everybody
Yeah.
everywhere.
When you mentioned, Meena, the um, alluding to it was just a matter of time. So I didn't make this metaphor up, but I heard it on TV. It's like flying on a plane, and same planes we fly on now, and allowing smoking and then having a non-smoking section, right?
Right,
Like,
exactly.
really? So it's inevitable, and yeah, I totally understand. And I was watching something last night, um, and it made me really aware of the challenge with COVID and the incarceration system. And it was actually somebody from ACLU, I think it was their head person, discussing about not just the people incarcerated, but the daily inflow and out, the throughput of people that come into jails, if you will, just even
Mhm.
visitors.
Mhm.
And if we don't get that under control in that setting, and I don't need to break down, and for the sake of this conversation, all the things they could be doing to mitigate it, but if it's not handled correctly, that particular the jail system and those incarcerated are going to continue to be a huge societal problem, not just for those that are actually in the system itself, just
Right.
because of the exposure that all of these folks are giving through the throughput daily of people coming through.
Right. That is a very scary system. I mean, in terms of the potential risk, in that sense, it's sort of similar to a nursing home, you could say, because it's people in very close quarters, so many people together. It's a different demographic population for the most part, but certainly an at-risk population. So that's been something that I've been also worried about watching.
Hmm.
I have a friend who is a doctor in the jails on the East Coast, and she's been so concerned about this too, for very good reason. And the other thing is that there can be a propensity towards violence in certain situations. There is what she was telling me. And so if
Mm.
there is an outbreak, in terms of how people would react, that's a whole another level of
Yeah.
safety issues, right?
Yeah.
But I heard, I believe it's in Guantanamo where they've had several positive cases, and we're thinking of releasing some of the prisoners who were positive, or not even positive, but more at risk of contracting it,
Hmm.
based on their age. And so, I mean, it just leads to so many very interesting
Hmm.
debates about,
Yes.
like you said,
Yes.
about the impact on society, about prisoners being released, and things like that. So yeah, I'm glad I don't work in that sector and have to make those
Yeah.
decisions. I'll put it that way.
Yeah. I think there's going to be, or let me put it this way, and I heard someone on TV say this, but there's so much opportunity on the positive side because you use the word society or societal change. There's
Mhm.
so much opportunity for us to start looking at at how we operate as a society when you go through these sorts of absolute crisis situations,
Mhm.
um, to change for the better on multiple of levels of how we work, how our institutions are set up, how we interact. Um, and I think that will be forthcoming as long as we have forward thinking leaders as
Right.
to how we move forward. I don't know that getting back to quote unquote normal is really the right thing. And I understand what we all mean. Like I love, wife and I love going to restaurants. We love that social engagement. Well, until there's a vaccine, I don't care what opens up here in Tennessee, you're not going to see us in a restaurant. It's just not going to happen. It's not worth the risk. But
Right.
so there is a sense for me if I understand that comfort of normal and socialization. But I also think just getting back to status quo isn't going to cut it. That on many levels, structurally, and how we engage as a society and a culture, we've got to make some significant changes for safety purposes, for delivery of care purposes, for those that are less fortunate. Um, so I just think this is actually an opportunity in a positive way to look at how do our forward-thinking leaders see us actually being a better society after experiencing this pandemic.
So
Beautiful.
with what Fred's saying, that's beautifully said, Fred.
Definitely.
You know, with that being said, Meena, do you have something that you could specifically give us a golden nugget per se for our listeners? And now our listeners are physicians or providers and patients as well. Under the current crisis, do you have something that you can add or tell us that we can hold close to our hearts during these stay-at-home times?
Well, for me, from my standpoint, again, in geriatrics, it has to be about that. So it's really about, please think about any elders in your life, or if you are an older adult yourself, please allow people to help you. Please reach out for help. But for the rest of us, please definitely be calling any older friends, neighbors, etc. See how you can help them in this time. A lot of people don't want to ask for help. But this is a time, like Fred said, where society is shifting already. And I think it's really a time for us to come together and reach out, especially to those more vulnerable people in our lives. And in terms of for physicians out there, with COVID and geriatrics, the presentation is so different than the typical what we hear: cough, fever, sore throat. So many older adults do not present with any of those findings. They present in such different ways, which I won't take your time to go into, but just keep that in mind, that when you're seeing your patients, or again, friends or yourself who are older and have just these kind of unusual findings, keep that in your mind. We don't want to miss that in this population.
Hey,
Well,
Andy.
Yes, go ahead.
So I told you before we went live that I was not going to end with a pearl. But I moved, Andy, so I'm going to
Go
give
ahead.
a pearl.
I want to hear it, Fred. Please enlighten me.
I won't go as far as enlighten. That's what Meena's here for, not me.
By the way,
No,
Meena, as Fred gets older, his pearls get longer. I'm just letting you know it's an observation.
Okay, I'm ready.
Go ahead,
just
Fred.
just wait till we're off air, Andy. You're going to pay the price for this. No, what had just occurred to me as we were having our conversation is this is a team sport, and this is not a time to be selfish. Yes, I'm at a high risk just based on being in my 60s, but um, and I know especially for young people that are feeling invincible, and this won't bring me down, and probably won't, thank goodness. But now is really a time for us to think globally. And I think it's interesting when we unfortunately have times like this where there's pandemics, all of the things that separate us suddenly kind of dissipate, and we all see how connected we really all are. And the things that we think separate us by national origin and socioeconomic situation and job title and all those things really are on some level an illusion. And the core things we have in common are just incredibly connecting all of us. So now is the time to think as a team, and it's a time to think of as we, not me. So I just encourage everybody to have a more broad spectrum sense of awareness about the impact that their actions and decisions are going to have, and not just think about a short-term inconvenience that this has on all of us.
Well said,
I love
Fred.
that. Yeah.
We appreciate that your nuggets, your golden nuggets, both Meena and Fred. It was both very insightful, very thoughtful, and I just want to thank you so much I'd also want to thank all of you all for joining us for this podcast, and especially want to thank Dr. Meena Makhijani and Fred Newmark. Please be safe, stay safe, take care, everyone, and until next time.
Thank you again for joining us. To subscribe to additional SMA podcasts, please visit sma.org/podcasts.